Managing length of stay by targeting low case mix index DRGs is our episode topic. My guest is Caroline Segovia-Marquez, a registered nurse and managing consultant with BRG's Care Transitions team. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Caroline, thank you so much for joining us today.
Thank you. It's a pleasure to be here.
Before we get into our episode topic, can you share a little bit about yourself with our listeners?
I have been a nurse for over 30 years, and prior to joining BRG, I've been a director of care management for both community hospitals and academic medical centers.
Our topic today is improving length of stay by targeting DRGs with low CMI but high excess days. And it's a continuation in a series of episodes that we're doing with the Care Transitions team around targeted solutions to reducing length of stay in your hospital. Just some level setting questions for our listening audience. What's a CMI or case mix index?
CMI is an indicator of how sick the patients are in a specific hospital. It's a combination of all the diagnoses and the relative weight of all this diagnosis combined into one. And it's an indicator of how sick the patients are in that specific hospital.
A higher a number, the higher the acuity and sickness that exists in that hospital. Is that an easier way of summing it up?
Correct.
And what type of numbers would we normally expect in a small community hospital versus a very large academic quaternary academic medical center?
So the CMI is like between 1 and 2. The typical hospital has a CMI of a 1.5. The higher it is to like a 1.8, the sicker the patients are, or the more complex the patients that this hospital is taking care of. A lot of the tertiary hospital has burn units, transplant centers. So those are like the highest or most acute cases that are in those tertiary hospitals that drive the higher CMI.
Great, thank you. And then what is a DRG or diagnostic-related group?
Grouping that is assigned by Medicare to each diagnosis. Each diagnosis is what they call a relative weight, which again measures the acuity of that diagnosis. It also drives payment, and it also drives the geometric mean length of stay, which is the average that Medicare assigns based on the resource consumption of each of these diagnoses.
Shifting gears or shifting into our episode topic, we've had many guests come on over now our 4th season talking about length of stay and ways to mitigate and manage length of stay. But in your own words, why is managing length of stay in the hospital so important?
Length of stay is a key performance indicator for hospitals all across the country. Shorter stays are associated with better resource utilization. Length of stay also means that you're managing your patients effectively. It improves bed turnover. It allows hospital to match the demand with quality, and it's resulting also to better access to care for patients who are coming through your emergency department.
Now, what are some strategies that we can employ to help reduce length of stay, particularly for low acuity patients with high excess days?
So managing length of stay is definitely a team sport. There's no one department that's responsible for it. It starts prior to admission to the hospital. One of the initial strategies to do it is to manage all your points of entry to ensure that you're admitting patients that are appropriate to come to the hospital. And once you determine that, you make sure that they're also assigned the right status. So for those cases that are less acute, they could probably be observation and not inpatient, and make sure that you assign that right on admission. Another area of opportunity that most hospitals currently don't have right now is looking at those elective procedures, starting preoperative case management prior to bringing the patients to the hospital. Some of the surgical cases are very short stays, so discharge planning could start even prior to them being admitted, educating the patient of what to expect when they get to the hospital and making sure that they're prepared to leave the hospital after their surgical procedures. Certain surgical procedures that are 1 to 2 days really doesn't give the hospital case management team enough time to work through the discharge planning. So having a proactive approach and doing that prior to them admitting to the hospital helps them a lot while the patient is at the hospital.
All right. So we talked about, you mentioned utilization review, and I'm going to come back to that in a moment. But just for a moment, why focus on low acuity patients? Why not focus on our sickest patients? They're the ones that are contributing to the longest length of stay. It seems counterintuitive that, hey, we need to focus on our low acuity patients to really accelerate throughput. Tell me more about that.
So the low acuity patients obviously has a shorter geometric mean length of stay assignment. So definitely they're only there for 1 to 2 days. Most of the insurance now pays for the diagnosis and not for the length of stay. So no matter how long your patient stays there at the hospital, as long as it's the same diagnosis, they could be there 3 days, 5 days, 2 days. If it's all in the same diagnosis grouping, you get the same amount of payment. So no matter where they are 5 days or 2 days, the payment is the same. So the hospital reimbursement is impacted by length of stay, especially with this low acuity DRGs, since there's not a lot of reimbursement involved, and then you keep the patient longer and it just adds to your expense.
So what I hear you saying, and this is actually similar to the work that's done in a lot of EDs right now, is you've got EDs that have put in fast track for years. And in recent years, there's been this larger push around vertical care and figuring out more complex workup patients that are still likely going to go home, but they require more complex workups. And how do we take those patients that we think are going to go home and really get efficient at managing their care, knowing that our sicker patients are more complex, more difficult to deal with, more difficult to get aligned and get all of those wheels properly greased and in a row and ducks in a row and aligning. And what I hear you saying is do the same thing on the inpatient side. If you've got a chest pain protocol, run it. If you're going to get patients in op status, put them in op status and keep them there so you can get really highly efficient at that, because on your really sick patients, you're going to have some problems on length of stay. Is that an accurate assumption, or am I way off basis here?
No, you are right on target with that statement. Currently, a lot of the hospitals don't are doesn't agree with transitioning some of the tests outpatient. So a lot of the hospitals, when the patient come through the door, they what I call the $1 million workup. Treat only the patient to what they came in here for the hospital. So stop doing all other tests that's not related to the actual complaint that the patient came in. Discussion of that really happens during interdisciplinary rounding. So if the patient came in for the congestive heart failure and there's no other issues, stop adding in a colonoscopy, because while they're there at the hospital, that can increase the length of stay of this patient. And I think there's a lot of work that needs to be done in a lot of the hospitals now, because they feel like the patient is not going to come back for certain tests or will not follow through when they get discharged.
Yeah, David Broussard actually spoke to that when he was talking about focusing on providers and providers as an opportunity to reduce length of stay. He said that he called it the while you were here. Like, while you were here, let's get your MRI of your shoulder for your rotator cuff. While you were here, to your point, let's go ahead and get the colonoscopy, and not really, while it's a patient convenience, not really understanding the downstream implications that has on overall flow for the organization. And frankly, the patient that's in the emergency department waiting to take that bed upstairs, and the patient that's in the waiting room waiting to get a bed in the emergency department.
Yeah, I think access to care is something that a lot of people don't understand. They only think about the patients that are currently bedded, not they're not thinking about the patients that are waiting to get care, who are much sicker in the emergency department than's currently sitting under inpatient units. A lot of that is still happening all across the country, and I think as healthcare providers, we can do a better job with patient throughput to ensure appropriateness of admission and accurate level of care assignment.
Other than having utilization review, UR or point of entry, I've heard the terms used interchangeably. I assume that they are interchangeable. Are there any other tactics that should be implemented or managed before or during the admission process, really to drive down that length of stay?
The other issue is when you're doing interdisciplinary rounding, there should be a robust discussion on the actual length of stay in comparison to the GMLOS. The nursing team plays a huge part in this discussion to regarding patients' ambulation status, diet progression, transitioning medications from IV to oral. We usually see a lot of delays in those areas. Pain management is another thing that we need to continue to work on to ensure that we're progressing the patient with transitioning some of the IV pain management or pain medication to oral, and also identifying patients' educational needs early on during the stay. We've seen a lot of cases that the patient is ready to go out a door, especially in the diabetic patients, and they're still, oh, we haven't done any teaching yet. So that's a critical component that should be all taken care of prior to having discussion about discharge. It's all part of the effective and efficient discharge planning process.
Can you give an example of how these components work and how it impacts the length of stay?
So, accurate documentation at the highest level of specificity, detailing the patient's story and capturing comorbidities and complications is also critical in managing the length of stay of these low acuity patients. For example, a patient with a simple pneumonia has a geometric mean length of stay of 2.1 days. If you capture and document appropriately CCs, which is comorbid conditions or major complication, you get your GMLS up to a max of 4.1 days. So that's additional 2 days if you have really good documentation in place. Another example is a patient with a heart failure. A patient with a simple congestive heart failure with no documented comorbidity and or complication has a geometric mean length of stay of, again, 2.1 days. You can get this up to another 3 to 3.9 days with accurate documentation of these comorbidities and complications. Telling this story is really important. The hospitals don't get paid for the care that they provide, but they do get paid for the documentation. The accurate documentation gets us the right diagnosis code that is, again, it's transposed on the patient's bill, and that's what gets paid for by the insurance.
All right. So what I hear you saying is documentation is really important. It's not necessarily going to impact length of stay, but what it is going to impact is how many days you get, how much you get paid for, what your revenue is going to be, what your ODE ratio is going to be, what your avoidable days are going to be. It's not going to change the fact that the patient's in your hospital 4.1 days or 3.2 days necessarily by documentation, but really on the payment side, what you're getting paid for.
Correct, because those comorbidities and complications increases the weight or the severity of your diagnosis. And a higher severity diagnosis could add additional days to your actual geometric mean length of stay, and that would help decrease your observed to expected ratio on your length of stay calculation.
Okay, thank you so much. So, if I'm a case management leader in a hospital right now, what advice would you give me about how to manage length of stay for patients with low acuity? We've talked about the different solutions, but all right, I'm running the ship right now. What works best, or what should I really focus on?
So first and foremost is you look at your data. What are the areas of opportunity? Your data can tell you what are these diagnoses that you need special attention. Look at where you're falling short. Look at some clinical or care variations. How did this providers manage this low acuity diagnosis? If your hospitals are not doing clinical pathways, start looking at some of this diagnosis that could benefit from using clinical pathways or standardized care plans. Start doing some treatments, start protocols, and start some of those treatments in the ED right away so that while they're waiting, if you got a hold in the ED, you could start getting the ball rolling and treating the patients as early as in the emergency department. Again, back to my example of congestive heart failure, start providing a protocolized IV diuretic in the ED so that you could start diuresing this CHF patient and not wait for such a long period of time before really doing aggressive treatments until they can get to the units. So those are some of the areas. conduct a root cause analysis. Look at your avoidable delay report. What's causing all these delays? Are there tests and treatments? Are there delays on your tests and treatments in the hospital? Partner with your team, the leadership team on some of those departments in making sure this diagnostic testing are done accordingly in a timely fashion, because those are some of the areas that are causing the delay. Engage your providers, educate them on documentation, educate them on appropriate patient status so that when patients walk through the ED with some of those symptoms, they should be placed in observation instead of being placed in inpatient. Utilize your bed appropriately. If you have an observation unit, make sure that you put your observation patients in there, utilize them, and discharge and have efficient throughput on those units. Share the data with your team is another thing too. When you look at your data, you make sure you share that data and ask them, get their insight of what else you could do differently in those areas that need improvement.
Any closing thoughts as we wrap up this episode?
Managing the length of stay is important for better patient outcomes. Patients should receive care in the right setting, at the right level of care, and the right amount of time. Reducing the length of stay leads to improved patient throughput and is influenced by everyone in the care team. So again, not one person is solely responsible. This results in reducing your ED boarding time, increased patient satisfaction, increased staff satisfaction, because now you don't have all these patients boarding into ED, especially for the ED staff, and overall improve access to care for all the patients that needing the care in your organization.
Improving length of stay by targeting DRGs with low CMI but high excess days has been our episode topic. Caroline, thank you so much for your time today.
Thank you so much, Nick. It was a pleasure being here.
You've been listening to the DRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.